I just wanted to draw your attention to some of the handouts. Hello. I'm really curious for feedback on all of them from you guys. We've got another iteration of those physical activity guides incorporating a lot of feedback that we had from Allison, who was here, from Physio, and also from Anne and from other people who sort of submitted some feedback. This one I did up from last time in response to some queries about interdisciplinary versus multidisciplinary care. Like, some of the people were saying that in their role, they don't normally do all the M's, and they were wondering about sort of core messaging for patients. So if they brought up something like urinary incontinence, and the patient said, well, why are you asking me about urinary incontinence, that they would have sort of core messaging. So I tried in this to go through each of the conditions and give a little bit of core messaging about what it is and how it could affect somebody in terms of some of their desire to do lifestyle change or make efforts around weight management. And then a little bit about who are the people that could be helpful to sort out that problem. Because I mean, when we start working collaboratively like that, it's not that each of us, like, I'm certainly not doing Jennifer's job. I just know to send people to her, and then they get the right counseling, right? So, and vice versa. Like, I wouldn't expect Jennifer to be doing the urinary incontinence, looking at cystoceles. I would want to see them myself, but I can look for the cystoceles and treat it, right? So, so this is what this is for. And if you guys think that this, I want to know whether this hits the mark. Like, is this what people were thinking of when they were asking for that? Do you want me to go ahead and, is it necessary to do it for the other M's? Or does everybody feel comfortable with the other M's, that wouldn't really be necessary, or should I do it up for the other ones? So those are my two questions for the team.
All of these we can provide electronically. So the gestational weight gain, you have the electronic version, but I'm happy to send these electronically if it'll be useful. I just don't want to fill up your inboxes with stuff if you don't actually.
Yeah. And then for today, for these slides, I've gone through, because thinking about prevention, and I've been trying to work out a medication pocket card that people can have. I don't have it for you today because Aria had a bunch of edits for it, and I think we need to do a little bit more refining. So we'll talk about that. Today is sort of intended to be dialogue. Okay. I've prepared some reflections on prevention to share with everybody, and then I want to know what people think. You know, are there pieces here that we've not hit? Are there things that would be useful from people's practical experience in clinic to highlight on this topic? And I got interested in this after we started doing this, because to be truthful, before I started working with this learning collaborative, I actually never really thought about prevention. I mean, anytime I ever saw pregnant women and I was measuring them and weighing them, I was always thinking about the baby. You know, do we have IUGR? Do we have, you know, or is the baby big for needs? Or are we getting into gestational diabetes because of its effect on the baby? Like, it's embarrassing, but you know, now that I sort of see the implications of pregnancy weight gain on women and their downstream health risks, sure, I knew, okay, if I had gestational diabetes, I had to treatment more aggressively for diabetes post. But I didn't really realize when I started working with Aria and working on this how difficult it was for people to really truly lose weight and maintain that loss. So I think there's been a huge shift in my thinking around prevention. And I'm curious to know, like, if other people had more of that in their training. Like, when you guys went through your training and through your professional development, did you have more of an emphasis on weight gain prevention, or was it something that's kind of new to other professions as well, as being so front and center? New? Okay. That's cool. I think there's something here that's really important for us to pay attention to. Ever since I started, I'm now looking in the EMR always at people's trends, you know, in terms of weight. Like, are they really, really steady for the last 8 years, or have they been on an upward trajectory just all around? And I think it's really shifted my thinking, because when you see how hard it is for people to intervene, you know, it's kind of like, try to prevent all of this from starting in the first place, or being as big of a problem in the first place. Okay. So that's sort of the point of the talk. What I did was I went to the literature to just see, you know, okay, so this is new to me. Is this new to everybody else? Or have people been working on it? So my first question was, is there any evidence that prevention works? And then I was thinking about life cycle stuff, because I got really intrigued by the pregnancy stuff, and I was thinking about just children and the stuff that we were talking about with Rhonda Bell about programming, you know, in utero and what the implications are later on. And so I was thinking about kids and adolescents and, you know, young girls that stop wanting to do any physical activity, wanting to go to the gym, and what happens in college with the freshman 15, and what happens with pregnancy and marriage, and, you know, these skinny guys that all of a sudden have a little, you know, tired. Like, what happens with menopause, what happens with retirement. So I got thinking about some of that. Stress and sleep, I think we've talked about it and obviously are huge. And I've been really reflecting on that a lot in my practice, I'd say the last 9 months. And then special issues regarding chronic disease and medication. So what are the things that we do to patients that set them up for trouble with regards to weight gain? And are there alternatives? And are there things we should be thinking of when we're making some of those therapeutic choices in an anticipatory way that we should watch for? So those are the kinds of things I was hoping we could cover. So, does prevention work? And at the end of this, I made one slide with all the references rather than crowding up all the references on every slide. So the last slide is a bunch of references. This is from a systematic review of prevention. And it was amazing. In adults, there's a very, very, very small number of published studies. And the studies are highly heterogeneous in terms of their intervention, and the lengths of them are really short, most of them. There's 2 longer-term studies out there. And of those 2, one of them was having people follow a low-fat diet and really increasing their fruits and veg. That was the intervention, and following them over 5 years. And the other one was a low-calorie diet plus boosting physical activity. And that one was crazy. They had cooking classes, they had group walks, they had all sorts of things. And in a lot of ways, I actually thought a lot of what they were doing for the intervention was very similar to what this PCN does, in terms of moving for health and the group classes and the weight management dietitian. It's very analogous, actually. And they did find that those 2 interventions were effective. And that's it for evidence. And they refer in that paper to pediatric evidence, which is equally sparse. So I think this is an area that, you know, one of the reasons we haven't heard about it in our training is that actually nobody's done much work on it. And it just seems to be an area that's coming out at me as being something important. So this one we talked about a little bit more with Rhonda, but most of the studies that exist with regards to prevention of weight gain in pregnancy are very poor quality. And the effects of the interventions are small, of what's actually published out there. And they have shown in this post-pregnancy period, this combined diet and exercise did result in significantly more weight loss. That was the best study that's out there. But exercise alone was not effective, which fits with what we've talked about with regards to exercise in terms of where it fits in the energy balance, and that it's something which is not going to be doing it by itself. Has all sorts of positive benefits, but not specifically on weight. And with regards to this, there was no adverse effect of this intervention on breastfeeding. So they actually looked at that, and there was no problem with breastfeeding with intervening on weight. So I think a lot of this is going to be, you know, extension from, okay, we would love to have the perfect trials, but what does our common sense say? And I mean, I think it all really resonated with all of us when we were looking at those gestational weight gain charts and things like that, and helping people sort of stay on track throughout their pregnancy so that they don't end up in an entirely different order of magnitude than when they started in terms of their weight. And so this was the same chart that we had with regards to singletons. And this is interesting because this was for multiples, and I didn't see that in the materials that we had before. So I gave a handout today on now this one's from BC. So there's Health Canada Nutrition for a Healthy Pregnancy, and they have the different charts we were using, and then they have them as well for multiples. In case we have clinics that we're interested in. So have you guys been having any experience with checking this out with any of your patients? So those of you that do prenatals, have you been using this? I know you've been doing some. What's patients' reactions been to this?
Well, sometimes I show them the chart and they're a little bit off, and then they kind of panic a little bit. When they're a little bit off, I always tell them like that's the normal weight gain, and usually we only follow them for 20 weeks, so it's not. They only start doing around 16, right? So it's a little early, but yeah. So I don't know if later on if they gain a whole lot more.
So it's been a tool so far that's been a source of conversation. conversation each time and
Yeah.
happy because,
Essentially.
yeah.
And some patients do actually add, like, oh, is that a normal weight gain?
Mhm.
Pick up the chart and show them.
Awesome. Have other people been changing their practice with regards to emphasis on this in pregnancy?
I've been using the wheel.
Oh, okay, yeah.
Because I have the pregnancy wheel. When I'm talking about that weight gain, and I find a lot of women are relieved to find that they can gain some weight and that it's important to gain a certain amount of weight, but not to overdo it.
Mm-hmm.
Yeah. It's awesome.
Anybody else?
I've been finding that this message is getting out there because when I talk to women about it, they're not surprised. They already know it's only like 500 extra calories in the second, third trimester. Like they already know a bunch of information and stuff. I'm happy. I don't have to drill it into them. So
That's awesome. So multiple messaging is getting out. That's good. Now we just have to get it out to physicians. Good. Okay. So I was looking at pediatric stuff, and I just wanted to highlight. So one of the conversations we had in one of our small groups some weeks back was on kids. And actually, I think just in the whole big group, we were talking about kids and lunches and peer pressure and bento boxes. I don't know if anybody remembers that conversation. But I was looking for pediatric stuff, and if you remember at the very, very first session on weight bias, I was introducing you guys to some resources from the Yale Red Center for Health Policy on Obesity. Has anybody ever checked out that website? Have you? Yeah, what do you think?
There's a lot of good information in there.
Mm-hmm. There's a ton of cool stuff for children. Yeah. Anybody else? Okay. It's a neat website. It has a little bit of a different angle. It's a bit of a health policy, a bit of an advocacy angle. And one of the things that really struck me as interesting in terms of prevention, so I was specifically looking at it again from the perspective of prevention, was this thing that they've come up with where they call it Red Roots, and it's this URL, redrootsparents.org. And it's actually an advocacy toolkit for parents for how to make positive change in their community and in their school around healthy eating for children and resources for healthy eating and removing high sugary drinks from school and increasing the quality of the food being served in the cafeteria and things like that. So it was interesting because I didn't find a lot of evidence around it, and in fact, they have a link on this to a thing called the Robert Wood Johnson Foundation, which is a research foundation that gives a lot of grants for this kind of research, primary care research in the US. And they had a whole bunch of different papers, and I was reading them, and I was actually kind of disappointed because some of them were on prevention in adolescents and, what's the effect on weight of removing sugary drinks, for example. And they did our randomized control trials, and the adolescents were having some initial effects over the first year, and they were losing those effects by the end of the second year. And it just speaks to how many other things are going on. So even though the children are eliminating all the pop and the juice and things like that, and they're getting some benefit, they aren't necessarily eliminating all those other factors which are contributing to environmental stimuli around perhaps not the best food choices and things. So it's a really challenging thing, I think, to intervene on. When you look at the evidence, there isn't a lot. I think when you look at common sense, encouraging people to get rid of the high fructose corn syrup, encouraging people to make those healthier choices, get rid of the fast food and stuff is really good. But there haven't been a lot of trials yet in adolescents to really demonstrate things that are effective. In children, the only things I could find were on reducing screen time. So I don't know, how many of you guys routinely see kiddies in your practice? So a few people do, yeah. What are the messages that you give? So aside from reducing screen time, get outside and run around. Any other messages for kids that you routinely give?
It's about knowledge, like for prevention, I talk when the moms are worried that the kids are eating too many treat type foods, and I do some education with the kids around what are treat foods, and as a family, is there, do you have maybe a family norm or a family rule about how many is considered appropriate in a day? So get families to set rules up, and not necessarily just for the child, but for the whole family as a whole.
Mm-hmm.
So just looking at and having children involved in food preparation, so whether that's helping with salads or helping even plan meals.
Talk about that, when you're grocery shopping, do you spend the majority of your time in the aisles or on the periphery of the grocery store? And I'm always amazed at how many people don't realize that all of the fresh, produce and whole foods are on the periphery. And they're astounded to learn that. So I always use that when talking with them too. But it's also a lot more expensive.
It is, isn't it?
I was in Superstore the other day, and all of their produce is in the middle of the store.
Oh, really? Right.
There it is. So,
They just changed that, eh?
yeah.
Didn't they just do a massive renovation?
But I'm wondering if a lot of stores are going to be rearranging things.
Well, that's good. I guess if you walk in the door and you get the fresh stuff first, that's
There's an advantage to that, but that isn't necessarily where you stop first.
Yeah.
Yes,
correct.
so it's something to be mindful of when you're using to the periphery of the store.
Good point. Okay. Awesome. Anybody else? Yeah?
Well, when I see parents, I try to, especially if the child seems to be a little heavier, I'll try to talk to them about not pacifying them every time with the food. Try other things first, distraction and things like that, instead of just putting a bottle in their mouth or giving them something to eat to stop them from crying or pacify them.
One of the neatest things that Robin taught me when she was giving us our teaching last summer, because she gave us a little bit of a sort of a synopsis of what you guys learned in the weight management. And one of the things that you said that really stuck with me was how little kids actually won't overeat, that they have that auto-regulation in place. And so I think since you sort of were explaining that, I've really found a lot of parents start to worry Johnny or Susie has stopped eating, because they get into past that initial phase and they go into sort of that around 2-year-old area where they just aren't eating as much, and they go through these different growth spurts, and that people worry about that. And so I've been actually telling a lot of moms, no, that's normal, and Johnny or Susie won't overeat. Like they're actually programmed. So when they are full, then they are full. And there's a neat resource on this healthyparents.healthychildren.ca that you guys have got books or materials. What we actually did in our clinic was we embedded this in our electronic medical record. So we have an option under our resources to have a lot of resources that we like, and we have that link right there. And I've been using this a lot. Like I've just pulled the webpage up with parents when we're in the room, and they have some nice stuff in there around nutrition for kids, just basic messaging and things. So I think some resources around what and how much and how to eat and how to make healthy choices, and that kids don't need to have juice. If they're little kids, give them water, it's okay, or milk, and they don't need to actually have juice and things. And increasing active play, I think, is a huge thing. I've got a pandemic of kids who spend a lot of time exercising their thumbs. Actually, I have one kid come in with a thumb strain. They're getting injured from using this, right? But it's a problem, and so the messaging I often give is to talk to parents about helping the child to grow into their weight. So if they are a little bit on the heavier side, I say, that's okay. They're going to continue to grow up. So what we need to do is hold the weight steady, and the height will catch up to it. So not to feel like they have to lose weight. I had one little one actually come in the hospital, come in my office in heart failure. She was 3.5, 4. And she actually had heart failure because mom was working with a weight loss type organization. And the little one, all she was drinking was cow's milk. So she ended up with significant anemia, and she came in and she was actually in heart failure. So we had to admit her to the pediatric ICU. So I think, messaging for parents that you don't want to have children on diets, that's not common, but I've seen it occasionally where, the baby is too heavy and worried about how much to feed the baby. And so getting away from that stuff too, because I think there's a downside of having all this obesity in the sense that the messaging can go the wrong way to children.
I don't know about everybody else, but we get a lot of phone calls from Healthy Beginnings saying, oh, this child is measuring and then our docs look at our WHO charts or whatever, and we're like, it's in the normal.
Yeah.
And so, but they're scaring the parents because then they go to this for an immunization and they're told their children are obese or overweight and what are you feeding them, and it becomes this like, I don't know about everybody else, but we found that in our clinic, and then we'll do like a healthy child check and we're like, well, they seem to be in the normal parameters, so then what do you do about that when they get quite upset?
Yeah, I've had it the other way where they've come in underweight, but actually, so one thing to remember about growth charts for children is that there's different charts for different ethnicities. So the WHO has them for kiddies who are, of Asian origin or different origins where the families are very tiny. I have that kind of going on right now where they had gone and mom came in very worried because baby was underweight. Teeny, tiny parents. Okay, and probably going to be a small baby. Small child, like genetically. So you really have to also make sure you're looking at the right charts, and making sure that the child is tracking where they're supposed to track, right? And that they're consistent on their curve, that they're not crossing curves. So we always pay attention when kids start crossing curves down, right? We go, whoa, what's going on? Or when they're under the bottom curve and they're less in those very, very low percentiles, you're really worried about weight gain. But I also think we have to pay a lot of attention when we start to cross curves the other way. And those are the times I think where we need to be nervous. Not just because it's a big kid and the kid's tracking consistently on the 95th percentile. That doesn't mean the child's obese, it just means the child's big, particularly if they're congruent for height and weight. Right? And so making sure that those things sort of stay proper messaging. I think there's a lot of guilt that we put on parents, and we need to not do that. So I think, for me, a strategy I found effective has been to sort of tell the parents, hey, Johnny or Susie will grow into their weight. That's okay. We just need to try to change some habits to get more active play. Because if you get a child out running around, and just tweak their snacks and stuff, then they will get back on track. Relatively easier than the rest of us. So, yeah. Menopause, I'm really interested in menopause because, but also I think, my observation has been a lot of women complain around that age. And so I was doing a little bit of reading about it. And there are definitely some hormonal changes which predispose people, and there may be some beneficial effects of estrogen supplementation on this issue. The problem, of course, is the effects of estrogen on everything else are perhaps not totally benign. So I'm not necessarily saying that that's a good approach. One thing I was reading, which I found really interesting, and I've really tweaked my interest, I'm not sure that's totally evidence-based yet, has been about stress reduction, mindfulness meditation. Does anybody prescribe that in their practice? I mean, mental health workers prescribe meditation or relaxation. I know you guys have a course here. Yeah. And you probably know the evidence better than I do, but there's been some trials where they've just trained people on meditation and actually had them lose visceral fat. And I think it speaks to some of this emotional eating piece, because I think people are so fraught and so overwhelmed in our society, single parents or just dealing with that sandwich effect of having sick parents and having children to raise and having all those busynesses that we have in our society. And also I think a lot of social isolation comes up a lot clinically for my practice anyway, that people get into a lot of emotional eating. And I think really sort of intervening around that way, I think can be something that is worthwhile pursuing with more research. I think there may be benefits from it. But diet and exercise have been demonstrated to be effective, but it's easier to do it for prevention and maintenance, as Aria says, rather than trying to lose weight once weight's been gained.
Well, and I've read, and I don't know, I'm trying to remember where I read this, whether it's actually evidence-based or not, but I read that with menopause, you would get natural fat deposition on the outside of your abdominal wall. So you get what they call the fluffy fat that deposits here. If you have a woman going through menopause and under stress, you get double fat deposition. You get it inside the abdominal wall and outside. And so that's where mindfulness training or some kind of better way to manage stress would help decrease some of that natural weight redistribution.
Yeah, and I only found one trial on it. but yeah, it's something I think that like all this whole area, as I've said at the outset, would really benefit from a lot more structured research, but it does seem to be something that's promising that can be helpful to people and really also help people boost their quality of life, you know, inner sort of satisfaction, calmness, that kind of thing. So I prescribe a guy called John Kabat-Zinn all the time. If you're interested to check him out, his stuff is fantastic. Okay, so social circumstances. So I was reflecting on this and saying, what do you tell patients when we think about this in terms of prevention? So I have been talking to people who've been sort of coming in with the perimenopausal stuff and saying, you know, it's important to be mindful that this might be a period in your life where you might be prone to gain more weight, and you might want to make sure that you're being vigilant, not sort of having your head totally somewhere else. And I think that's all you can really recommend with a lot of these different life states. But job loss, changing job, going to college, all these different good and bad stressors. You know, moving from, I know when I lived in Toronto, I didn't have a car. And you walked and walked and walked and walked and walked and walked and walked. And then you move and go to do residency in another city where you have to drive. And you're up 36 hours. And there's always chocolates and brownies on the nursing station at 2 in the morning, and you feel very hard done by 4 in the morning. And when you're sleep deprived, you really want eggs and bacon for breakfast at 8 in the morning. And then you're kind of crying on the ward as you're writing by the time you're there for 32 hours. And then you go and have a good lunch, and then you go home and fall asleep at the stop sign, and then you fall asleep. Catastrophically bad for weight gain, I can definitely say, you know, so, you know, I think all these different things people have to do to strategize. Shift work is a big one, right? People working shifts, those cycling shifts and getting those circadian rhythms out of whack, and just helping people to try to strategize ways that they can be healthy when they're working in these very abnormal rhythms and ways that people have to do, especially in healthcare. And military too. Prevention of weight gain with smoking cessation. So I was really interested in this because I find it comes up a lot, and I was just curious about what the evidence was. So what I was interested to know, there's citations again in the back, is that using NRT or varenicline, so Champix or bupropion, all can limit weight gain during treatment. They've proven that with studies. What's much more unclear is after treatment whether or not those things persist in the long term. And I suspect that smoking is an appetite suppressant. It's also something that people often do for anxiety. So one thing I think is really a helpful strategy is when you're counseling patients around smoking cessation, I always get patients to write down for me why they smoke, when they smoke, where they smoke, with whom they smoke. Picked up a lot of alcohol abuse that way, but also a lot of times a lot of hidden depression and anxiety underlying. And when you remove the smoking, that anxiety comes up. The other thing that I didn't know was the whole effect of caffeine. That caffeine gets really ramped up when people quit. Did you guys know that? I didn't know that for the longest time. I just found that out I think a year or so ago. Yeah, and that's huge, right? So if people are used to drinking a double or whatever it is, hopefully I'm going to replace the double part, but anyway, whatever. They're used to that, right? When they quit smoking, the effect of that in terms of the caffeine on their body makes them way more jittery and anxious. So if they were treating their baseline anxiety that 10% of the population has anyways with smoking to start with, and then they get ramped up with the caffeine and they don't moderate their caffeine intake, they really can get quite jittery and then they can get into a lot of emotional eating. So that might be part of it. So it could be that the tobacco is actually an appetite suppressant. It could also be that it's having an effect on the anxiety and emotional eating. It also could be an effect on nausea. So a lot of patients with GERD and nausea and stuff will say that when they smoke that it calms their stomach. So I think exploring a little bit what's happening to patients, because then if they're having those kind of symptoms and they find that they're relieved by food, then they may be overeating because of the GERD. So exploring a little bit if there's underlying stuff going on there might be a helpful thing. That's not evidence-based, that's just anecdotal from me. There's been some studies on exercise, and that if people get into like this is a time when if they get into a really good new walking program or some sort of other exercise regimen, that's been shown to be effective on limiting post-cessation weight gain. All the interventions that have been studied, these are all systematic studies, have been modest in terms of their effect. And these are sort of their bottom lines that they suggested. So those other things, so all of those ones were effective. Just doing those things in terms of the actually following up with people and doing goal setting and all that good stuff that happens in our organization works. But just giving people education and sending them on their way doesn't have any effect. So sort of more justification for what happens in PCN, I think. So then I got thinking about drugs. And I found a really neat article which sort of talked about it and gave some kind of pearls for things to think about. And to be truthful, I have never ever thought about this in prescribing, which is embarrassing up until the last couple of months. And I think this is maybe a message that needs to get out there a little bit too. So one of the things is in people who are at risk, so people who are already definitely having issues with weight, there's some drugs that are known to cause more than 7% of weight gain. And their point was try to avoid at all costs those drugs in those patients. The second thing is there's really, the literature around weight gain with drugs is really heterogeneous. It's not like every single person who takes the drug gains weight. It just may be that it's a drug where a lot of patients gain weight, but it doesn't mean everybody will. So if it's really a necessary therapeutic option, to just pay attention when you start. So when we see them back to assess the effect of the medication on whatever thing that we were treating in the first place, to actually weigh them and find out and make sure that they're not experiencing any adverse weight changes just at the get-go. To really think about weight gain as an adverse effect of medication, not just as one on that long list, but really reflect on it a little bit more. And really bring patients into this discussion when you're doing therapeutic planning so that you can really balance the benefits and the harms of the medications with the patients to boost adherence and also to boost their awareness that this is something that they need to be mindful of. Again, to increase that personal vigilance during that time so that they can see what's going on. Use the lowest possible doses of medications. And this is something I get in fights with periodically with the consultants because they'll slam the patient on 80 of a statin and I'll put the patient on 10 or 20 of a statin, right? Those kinds of things. We don't want to slam patients on the highest possible dose. We want to titrate up slowly and find the level of the medication that gives the best effect to the patient to deal with what we're trying to treat, but minimize the potential side effects, including weight gain. And if weight gain occurs and you're not at your therapeutic goal, to consider adding another medication that doesn't have weight gain as a side effect. So really to think about that as part of the decision making in terms of the choice, which I don't know how much of that actually happened. And then to develop a plan with the patient to really make them a partner in this with regards to the monitoring, because you're not seeing them necessarily even every month. And so they need to kind of keep an eye on how things are going and follow up, and they need to know to be watching. So those are the general considerations from that paper. So to go through some specific examples, and I know not all you guys, some of you prescribe, some of you don't prescribe, but I think being a partner on some of this and having this awareness could really bring it back to the docs a little bit to say, hey, maybe we should think about some other options here. So for contraceptives, there's sort of this feeling out there that they're associated with weight gain, but actually evidence doesn't bear that out. So combined contraceptives are the sort of lower dose ones that we now use. There's insufficient evidence to say whether or not they have an effect, but it certainly isn't large if there is one. And for progesterone only, again, quite modest, and not sort of an escalating pattern that you'll see with some of the other drugs. Depot drugs are problematic, and they're problematic for many other reasons, so they've really fallen out of favor. We don't use them very often anymore because they have black box warnings for osteoporosis. For diabetes. So diabetes is a real interest of mine baseline. In type 2 diabetes, the only drug that has any evidence of benefit is metformin. So if we're talking about patient-important outcomes that patients care about, like cardiovascular disease, death, anything, the only one that has any benefit is metformin. So in my practice, I really try to get patients on metformin and really try to push metformin, and it's weight neutral. Our second line on the guidelines, sulfonylureas, are associated with about a 2 to 3 pound weight gain. Less evidence as to efficacy. Our next line on the guidelines is insulin, insulin's associated with 4 to 6 pound weight gain, and in type 2 diabetes, there's no evidence that insulin is beneficial. Really?
Relatively speaking.
Yeah.
To your
So,
risk.
yeah, so I don't have patients running around with an A1C of 13.5, right? But there's some big papers came out last year in around what is the target. You know, we used to try to push people under 7 for an A1C. Probably harmful. 7.5 is probably okay. If I have anybody with an A1C under 8, I don't even consider insulin. So yeah, you don't want somebody running around with an A1C of 11 or 13. You know, they're going to get into problems with that. But when you look at systematically derived evidence of patient-important outcomes in terms of target organ events, there is no evidence that insulin's effective in type 2 diabetes. That is not true for type 1 diabetes. In type 1 diabetes, there's really big trials, hugely important. So I'm not talking about type 1 diabetes. Huh?
Life-saving.
Life-saving, like they'll be dead. But also from a cardiovascular perspective, tight control is important in type 1 diabetes. Okay. These newer agents, there's no studies of any endpoints. All of the studies are on lowering of hemoglobin A1C, so surrogate markers. There's no studies which tell us what happens to patients. And that's the thing with insulin too, there's just no studies, it hasn't been done. So the bigger things in terms of outcomes for type 2 diabetes are blood pressure control and statins. So statins, and you know there's a big debate. Do you treat to target on the LDL? Probably not. Make sure they're on a moderate dose statin and get that blood pressure down. And get them to quit smoking. And I think in our setting, you know, we can get patients to do hard things, but it takes time. A patient of mine I had yesterday, she used to refuse to believe she had diabetes. She had an A1C of 13.5, and she finally agreed to take metformin because she was getting really bad vaginal infections. So I put her on monostat and metformin for her vaginal infections. Eventually, she got religion. She had already had an aortic bypass, and she smoked at that time. So it was total vascular path. She started walking, and she changed her diet. And she got her A1C down to 7.8 with metformin, walking, and change of diet. Then her bypass started acting up again. She stopped being able to walk. A1C goes up to 9. Goes to the hospital, gets surgery, can walk again. Her A1C is down to 7.5. So it's not every patient, but I think putting that effort in on this, and she quit smoking. Yeah, she's still on Chapix, awfully, anyway. But she had smoked for 45 years, and she quit. So, I mean, I think in terms of the things we have evidence for, the quitting the smoking, the walking, right? We know that from the diabetes prevention trials, that if you have patients who are pre-diabetic, and you get them to walk 150 minutes a week, you will reduce their risk of developing type 2 diabetes by 50%. It's more than metformin. So I'm not saying that these things don't have a therapeutic role and that they're not important in some patients and we don't really know what's happening, but we still use them and that's fine. But I would submit that we shouldn't be doing that at the expense of the tough work, which is the smoking cessation, the getting them walking, really driving home those messages, which are time-consuming and difficult and challenging, but are going to make transformative difference to the patient's outcomes. We know that, right? And these other things, I mean, I just think that, you know, I know diabetes is a really rare condition. And I know it would be extremely difficult to generate money to do proper systematic research in this extremely rare condition of these medications, which were multi-billion-dollar. No money is generated from these drugs. There would be no reason to do any systematic research to actually know whether or not they work for patient-important outcomes. Right?
Blood pressure's going up.
What's that?
Your blood pressure's going up.
Don't get me started on some of these drugs. Because I think they may be useful, but I would really like to know what the effects are on my patients.
Is pioglitazone Avandia or Actos?
Active.
Active.
Yeah, so you're right, so I don't use this one at all because of the, now, extremely low level risk of heart failure, right? But the whole deal with the rosiglitazones was the heart failure risk. But again, you know, multi-billion-dollar blockbuster drugs, but no systematic research of any benefit to patients in terms of patient-reported outcomes, right? And that's my bone with it. You know, if we actually had the studies and we knew that there was X amount of reduction of heart attacks or X amount of reduction of whatever, then we could balance it with the fact that there's very low rates of heart failure, right? But the fact remains that there is no really high quality systematically derived evidence of benefit. And now I saw something recently wander by where, because there's been a whole thing in the last few months that was very controversial and everybody was fighting about it in the literature. Because the FDA has now reversed itself in terms of Avandia, and there's people sort of fighting on both sides of that. So there was a study suggesting that maybe it wasn't as harmful and stuff like that. And yeah, it lowers A1C, but again, you know, where's the evidence of patients? Where's the big, well-done systematic trials to show evidence of in terms of patient-reported outcomes? Right. So I just don't want us to lose the messaging. What you guys do in terms of actually having time for patients to get patients to make significant change on lifestyle is huge. It's far more important than most of what we do with medication, with the exception of metformin. Okay? Sorry, I can get excited about diabetes. Okay, mood stabilizers. So all the SSRIs have really, the literature was really confusing and I don't completely understand it. They have idiosyncratic effects on weight. So there's some sort of benefits to weight initially and then long term there's some suggestion of weight gain. On the cards I have it, I think some of them were certainly better than others on the list. I think sertraline was quite reasonable. Celexa was probably a little bit more problematic, which is bad because that's one I use all the time. Venlafaxine is weight neutral, which is SNRI. The TCAs are all associated with weight gain, and lithium is associated with weight gain, quite a lot of weight gain. Now, with the TCAs, that's very dose dependent. So I think if you have patients on a whiff for migraine prophylaxis or for trigeminal neuralgia or for urinary incontinence at night or whatever, I don't think I would change my practice based on this. I think it's probably more of a dose thing. But it's again one that I would probably watch and see what's happening.
What about Cipralex in relation to Celexa? Same?
I would imagine it would be the same. So Cipralex is another one of those fun little marketing tools. So chemistry-wise, every molecule has mirror images of it. So it's called enantiomers. They're exactly the same molecule, but a mirror image. Cipralex is just taking one of them.
But doesn't it bind to the does it? The
Do I
serotonin
believe
receptors
that?
a little bit more?
Do I believe that?
I don't know.
I don't.
Okay.
I think it's a marketing gimmick.
Yeah.
There's a really nice systematic review of all the SSRIs, and it doesn't actually look like they work very much.
In terms of anxiety, anecdotally, I see people do better on Cipralex than they do on Celexa. But
if they have the coverage, I don't care if they have that in enantiomer. I don't know that anybody knows the answer to the question, but whether it does change your weight.
but the weight is probably about the same.
Yeah.
And there's a lot of SSRIs that are a lot worse for weight than
Yeah, which ones?
which is the one that they give to anorexia patients to make them eat, and then they gain weight.
Paxil, there's fairly good evidence to support that you can gain significant amount of weight on Paxil.
Yeah.
I've seen ladies who gain 50 pounds on Paxil. Now, I'm not saying that's just the medication, there's probably some lifestyle stuff there too, but.
Yeah. And I don't know, on the medication cards that we're going to try to do, we'll try to flesh that out a little bit more.
I remember asking, I mean, it was a long time ago, but I think it was Weight-Wise or somebody, of the SSRIs, which one do you guys use?
Well, I know they use Wellbutrin.
Well, yeah.
And I think Celexa is one of them, but.
And I think sertraline is quite good. And then Aria was the one that said venlafaxine was weight neutral. So.
What's the other name?
Effexor, okay, yeah, that's the other one he talks about. Antipsychotics are tough, but how they'll graph. So this is a systematic review of all of them. So you can see these ones up here, like some Haldol, Piprazole, which is Abilify, are on the better end of the spectrum, and then you can see some of the other ones, the Olanzapine and things, are worse. This new fashion that we have for putting all of these non-psychotic patients on Seroquel for sleep as an adjuvant to SSRIs, I'm not convinced. I've been seeing psychiatry doing that a lot the last couple of years. So from a weight gain perspective, I'm not convinced, and I'm just really getting people to do meditation to try to help their sleep. Do the relaxation, do the meditation. Short-term things, try things like trazodone that are very innocuous and stuff first. I mean, there may be a role for some of these things, but I'm not sure about antipsychotics in a lot of these patients, and particularly given some of the effects that they have on this. That's just a preview. Gabapentin for antiepileptic agents, and we use it for pain. It's very dose dependent. So the literature looks like it's very, very dose dependent. So the lower dose, really pretty reasonable. You start to get to the higher doses. I had a patient on it for trigeminal neuralgia. She was on 5,400 a day. So really associated with a lot of weight gain at that dosing. And so all these are, topiramate actually causes weight loss. So this is an example of if you had somebody from their seizures, well controlled on, say, carbamazepine, and they were neutral, great. But if they were gaining weight, you might want to try switching to topiramate. Or if they weren't having seizure control, you needed a second one, you might want to add topiramate. So this is an example where you might want to think about that, especially if people are heavy. These are other medications associated with weight gain and some different options for them. Sometimes you just have to deal with it. And obviously people need to be on steroids for chronic severe conditions. It's a challenge. It's a challenge. But I think just trying to do the vigilance and trying to find all the other options you can, work with the consultants to try to find better options. There's many, many medical conditions that people can get that can cause weight, be associated with weight gain. And they broadly lump them here in terms of metabolism, muscle mass, issues, mood, and sleep. And some of them are easy to treat. Treating thyroid disease is very easy generally. Muscle mass stuff, that's multiple sclerosis, myasthenia gravis. Those are just challenging conditions where it's a lot of dietary intervention for the patients because there's things you can do with regards to muscle stimulation, for example, in post-stroke or MS, where you can actually do some muscle stimulation with electrical devices and things to try to keep muscle mass. I think physio is huge in those conditions to really help people from getting contractures, keep them limber. It doesn't tend to knock off all of the muscles, so trying to get people to do as much exercise as they can. Helping people to get into water and do water exercises if they've got MS and they can't work against gravity, at least getting them in the water and getting them to work. I've seen really amazing things with MS patients being able to preserve function with having a really good physical therapist and really good exercise program, but it's hard. And the amount that they can exercise is not a lot, so there's a real risk for weight gain, which can further affect function, and that really gets into very close work around dietary modification. The sleep we've talked about before. I think respiratory disease, we have to add that to the 4M card, respiratory disease. I think poorly treated respiratory disease, particularly asthma, is really a problem. And we can really use our RTs more to make sure patients have asthma action plans in place. No patient with asthma should say to you that they can't exercise because of their asthma. That means we're not controlling their asthma well. And there's a very small number of patients who really do need to see a pulmonologist and really do need some of those really heavy medicines because they just can't get that control of their asthma. But for the vast bulk of people with asthma, if we do a good job on controlling and educating and making sure they're using the medications correctly, they should be able to run, okay? And so I think this is something that we really need to make sure we're attentive to in children, attentive to in adolescents and in adults, because we just need to make sure we're using our colleagues and getting people the capacity to breathe. Because otherwise, if you can't breathe, you're going to do everything you can to conserve energy because you don't want to be breathless. It's an unpleasant feeling. And they have done some studies in the area, but the studies are really weak. Like it's an area, like all of this is just, you can stay busy for 50 years doing studies because there's just not much. PCOS is one that we see, you know, or anovulatory conditions, so premature ovarian failure, things like that. And these conditions lead people to metabolic syndrome and to diabetes. And they're challenging because there's this hormonal drive that contributes to weight gain. So metformin can be effective and lifestyle change can be effective. So I think it's a really big piece of education. And just help, and then just also acceptance. Like it's going to be a chronic issue that's going to make it harder for people. I looked at alternative therapies. I was interested in green tea because all my Chinese patients will tell you that it's very good for weight loss. Very good. I have a huge big, I have so much green tea at home. So people give me green tea. So sadly, the structured evidence did not support. I would be sorry about that. There are some systematic, I don't think it probably has lots of health benefits, but as far as weight loss, it wasn't one of them. At least not in the RCT kind of trial. I don't know how blinded you could be to green tea use versus not green tea use. Yeah. So I think, you know, what I sort of have learned from all this that we've been talking about so far is just how important prevention is. I'm shocked, actually. I'm quite thrilled, in a way, as a researcher, to have all this posse of data about prevention, because I think there's a lot of work we could do. I was also, it's really made me rethink prescribing, just to even be more aware of it, because to be truthful, I have never really thought about it. You know, you're always so focused on the condition the person has and the concerns that they're bringing forward, and you want to make them better from that chief complaint. And your headspace is very much there, where what they're complaining of. And I have not, you know, I don't want to give them things that are going to interact to kill them. So you're kind of looking for those X interactions or D interactions. But the side effect of weight gain as a risk factor for future harm for them has not been on my radar. So I suspect it's probably not on a lot of people's. And I think that's something that we have to dialogue, we have to change. I think maybe we need to, when we know how hard it is to have people, help people to lose weight. I think if we can try to do things to help prevent them from gaining weight, that'd be helpful. And I think, I don't know, I'm curious what you guys think. I mean, it's hard. What do you do about some of these things? I was like monitoring, like paying closer attention, watching what people are on a week-to-week basis, but I don't know. What do people think?
I know for the people that I see periodically, so the diabetics or the weight management folks in clinic that come in periodically, I talk about some of that life cycle stuff. So what's changed in your life, what's happening, how are things going? That kind of from a prevention standpoint. So, oh, my job's changed, oh, are you sitting more? So we try to get them thinking about how the changes might impact. Or when they come in and their weight is shifted, either up or down, we'll then take a look at, so what happened, what did you do, what do you think might have caused that? And do you want it to continue going, you know, for now? And so is that something that you're focusing on, or is this just something that happened? So really getting them to look at their whole life and having me do that as well, but getting them also to look at all the things that impact their overall health and weight.
I think it's a cultural shift, right? And then it's maybe starting. So healthy food in schools, the way we pack our kids' lunches, you know, making more awareness about fast food on every corner, that kind of thing. So maybe it'll take a whole generation to fix, I don't know.
Active travel.
Active travel.
Walking.
Yeah.
Livable cities.
It's really tricky. I haven't had a chance to talk to Danielle about this, but she had just referred a patient to me who has been diagnosed with bipolar, and she has psychotic bipolar, and she's on a depot injection, and she's had a weight gain of over 50 plus pounds. She's so sick. Psychiatrically, she is so sick. She's on a contract with the government that she has to take the depot. She's mandated. I'm not going to be, I referred her back to her psychiatrist. I mean, there's nothing that I'm going to be able to you know,
Yeah.
she's
Well,
so
and,
sick.
and that's it, right? And so having that knowledge
Mhm.
in our profession of the health states people have and the effects that it has on their weight, and then when they need a new knee, not telling them they have to be losing 50 pounds, right? Because
I mean, she thinks she's possessed by demons, right?
Yeah.
When she's off the medication, and
yeah,
even fluctuates when she is on the medication. And so we talked about, you know, increasing her level of activity, and she did have a referral for, you know, moving for health, but she's grossly inappropriate when she's sick.
well, I think part of that though is the benefits of activity in terms of, so how terrible to have to live with this condition.
Oh,
right?
it's terrible.
Terrible. And so the thing is that how do we meet her where she's at to help her? So is she totally inappropriate for help if she stays
She would
on her
be-
treatment?
In my opinion, right now, in a group setting, she would be grossly inappropriate.
Because she wouldn't be able to manage. Yeah. So then the question is, what can we offer her?
But apparently when she's lucid, she functions very, very well. But the day that I saw her, not very lucid. No. No.
Yeah. Yeah. What do people think?
It's really tricky. I mean,
It's very tricky, and these are a lot of, we have patients like this, right? So this is not, 1% of our population has schizophrenia. Probably another percent will have some other realm of psychosis. So it's not like in this PCN, in our PCN.
They would benefit more from one-on-one exercise counseling and just maintain that relationship so that when she's in her lucid moment, she can come to you and, reconnect and knows, who her team is.
which will be, probably quite inconsistent right now, and exactly.
But I guess
We're not going to make any changes to the amount of weight that she has gained with that pattern.
no, but we may be able to help her health
Jen.
by having her know that there's a trusted place that she can come and feel like she's part of the community.
We have a patient,
Yeah.
Jen, at Grey-Nun, who is on multiple psychiatric medications and, sometimes she's almost catatonic at our appointments. But she keeps coming back and she's working on it, and sometimes she's less catatonic than other times. And I mean, in some ways you think this is hopeless because she is on these medications that are just driving this weight gain, and she's like almost not even like drooling almost at times. And, but yet, she
If this-
comes with her aid and
If this woman had a conversation with anyone else in the group right now, she would scare people.
yeah. it's not
Oh,
good.
sure. Well,
Yeah,
that's,
dementia
but
patients
that's,
are-
but I guess it's our question as if we're going to be holistic and wrapping care around the patient, how can we, as a team, work to support special patients that need something different? Do we have are we a medical home for everybody or only for some people? And if we're a medical home for everybody, then we need to challenge ourselves to say, okay, well, what can we offer? What can we do? Are there things we can do? And absolutely, it won't necessarily be one size fits all. And you're right, these patients are so challenging, right? Like with regards to the chronic disease, I have a gal who's gained a tremendous amount of weight, 50 pounds or so the last year. She has really bad Crohn's, and she was on heavy medicines, and she gained all this weight, and she feels terrible. And what do you do? Like, how do you help? Because, with Crohn's, there's so many things that they can't eat. And then you've got these heavy medicines. And so how do you help patients? And this isn't just a few patients. This is a lot of our patients. So, I think we can do what we can do with who we can do and do the best we can. And then be there for everybody else, right? And then also just I think we need to change the perception in society, as we talked a lot about weight bias, to really get people realizing that a patient's or person's physical appearance be reflective of so many other things going on in their world, and not to make judgments about them as a person based on how they look.
And the guilt, that is such a huge part, like you were talking about the menopause thing. And people will come in and they'll be like, well, I know it's not menopause, but I know it is, they've been told, well, that's all in your head and whatever, like why put that guilt on the person?
right? Or I have a patient that comes to mind who's on big doses of steroids for severe asthma. And every time she's supposed to see her respirologist, it's, well, 90% of your problem is your weight. This is what she tells me. I don't know if that's what's said. Well, how reasonable is it to expect her to lose a ton of weight when she's on this huge dose of steroids? I mean, like, to me, maintaining her weight would be a huge accomplishment. But it's this guilt. It's 90% of it's your fault because you are overweight.
Well, and then I've had patients, very similar type of patients, so then she is self-titrating how much medication she's giving herself because she doesn't want to gain much more weight. And then her asthma blows out of control, and then, like, it never gets controlled because they're afraid to take their meds because they don't want to gain weight. And it's that conversation, right? It's challenging. So it's...
And do the people on the other end of the consultancy actually realize what's really happening? They just see these huge doses of steroids and this badly controlled asthma. They don't realize what the compliance is or why the compliance is. I always tell med students, so, I don't think there's such thing as a non-compliant patient. I think there's a whole bunch of patients where we don't know their values and preferences as to why they're making the choices like they're making. Right? So, I always tell them, don't come to me and say the person's not compliant. Come and tell me why. What is it that why are they choosing the choices that they're making? And maybe in their world, those choices make a lot of sense. And if you don't know what's really going on, then you really can't help. Oh, you're taking your meds every third day because you'd like to feed your grandchildren. I get it. I'm okay with that. I need to help you get med coverage because you can't afford your meds. I find financial barriers are often something that patients are so scared to bring up. And they're big, right? There's a lot of people that can't do what they want to do because of other really reasonable barriers, and they're making really reasonable choices for the environment that they're in. Well, that's why I think it's important that we actually really talk to patients about how effective meds are in the first place and make sure we make regimens for people that are going to be trying to achieve their goals of making them as healthy as they can and give them a realistic expectation as to how useful those are going to be so they can weigh those costs and side effects. But yeah, there's those thorny patients where where the situation is just such where it's very, very challenging, isn't it?
I ask a question about the PCOS and the metformin. So metformin's weight neutral. So how does it help in that condition?
I think it's, I don't know how it helps. I don't know if it's because, I don't know the answer to that question.
I think it helps because of with the blood sugar control. So, so their blood sugar is better managed, and so they have less spikes. So less hyperinsulinism.
Cravings.
Yeah. And it just, that's from my understanding.
Yeah. Okay, makes sense. Yeah. And then the activity piece,
So I had a patient come because they wanted to be started on metformin for weight loss, but they don't have PCOS, so I can't do that. But I don't know where she got that. She must have found that from somebody she knows, or
yeah. Well, that may be that somebody she knows may have PCOS.
and it would have been weight. I said it's going to be weight neutral for you. Like it's not going to help you to lose weight.
Yeah. So this is really in those gals who are truly PCOS and have all those different effects on their glucose and stuff. Yeah.
It has to do with the insulin resistance and stuff. But probably not for you or I would really work for it.
But. Any questions, concerns, worries, thoughts? Good. Take a break and head to another coverage. And I'm going to work with Aria to make up little pocket cards. I know not everybody prescribes, but just so you have that, so you can sort of have it on your radar screen if people think that's a useful thing.